If you have peritoneal mesothelioma and you're being evaluated for cytoreductive surgery with HIPEC, you'll probably hear your surgeon talk about something called a PCI score, or peritoneal cancer index. This number, ranging from 0 to 39, is critical for determining whether you're a surgical candidate and what outcomes you can expect. Today, I want to explain exactly what the PCI score measures, how it's calculated, why it matters so much for surgical decisions, and what your specific PCI score means for your treatment options and prognosis. I'm Terri Oppenheimer. I've been writing about mesothelioma and asbestos for the website mesothelioma.net for over a decade. I'm not a physician, and this is not medical advice. But understanding PCI scoring helps you evaluate whether surgery is appropriate for your situation. So let's start with what the Peritoneal Cancer Index, or PCI, actually is. It's a scoring system that quantifies how much tumor is present in the abdomen and where it's located. It was developed by Dr. Paul Sugarbaker, who is a pioneer in treating peritoneal surface malignancies, and it's used as a standardized way to assess tumor burden and predict surgical outcomes. The PCI divides the abdomen into 13 regions and scores tumor size in each one, creating a total score that represents overall disease burden. This provides an objective measurement of how extensive the disease is and helps surgeons determine whether complete or near complete tumor removal is possible. Here's how PCI scoring works. The abdomen is divided into 13 regions, 4 quadrants of the abdomen: right upper, left upper, right lower, and left lower. The upper jejunum, which is the first part of the small intestine, the lower jejunum, the upper ileum, which is the middle part of the small intestine, and the lower ileum, which is the end of the small intestine. Then there's the right colon, the transverse colon, the left colon, the sigmoid colon, and the rectum. In each of these 13 regions, tumor size is scored on a scale of 0 to 3, with the designation starting with LS, which stands for lesion size. LS0 means no visible tumor in the region. LS1 means tumor nodules up to 0.5 centimeter. And LS2 means tumor nodules between 0.5 and 5 centimeters, which is basically from pea size to about 2 inches. LS3 means tumor nodules larger than 5 centimeters or multiple smaller nodules forming confluent masses. That's a lot of information. And before I go on with more detail, I'm going to take a break here and ask you a quick favor. If you find these videos helpful, hit the like and subscribe buttons below to make it easier for other people who need this information to find us. And if you have questions or there's a topic you'd like to see addressed in a future video, send me a note in the comments section. And make sure you watch until the end, because I'm going to give you valuable information on where to find resources that could make a real difference for you. Now, the scores from all 13 regions are added together to create the total PCI score. Since each region can be scored 0 to 3, the maximum possible PCI is 39. 39 would be if every region had LS3 disease, and the minimum of 0 is if there's no visible disease in any region. For a concrete example, imagine a patient where the right upper quadrant has several 2-centimeter tumor nodules. That's LS2. The left upper quadrant has small nodules under 0.5 centimeter. That's LS1. The right lower quadrant has a 6-centimeter mass. That's LS3. And the left lower quadrant has no visible tumor. That's LS0. The jejunum regions each have a few small nodules, LS1 for each. The ileum is clear, so that's LS0, and the colon regions have scattered diseases of varying sizes. When you add up the scores from all 13, you might get a total PCI of about 18. This number represents the overall tumor burden across the entire peritoneal cavity. How is PCI determined? Ideally, PCI is calculated during surgery when the surgeon can directly visualize the entire abdomen. The surgeon systematically examines each region estimates tumor size, assigns them scores, and calculates the total. This surgical PCI is the most accurate because the surgeon can see and feel tumors, inspect areas hidden behind organs, and assess any disease that imaging can't detect. Sometimes it's the radiologist that estimates PCI from CT scans before surgery. This is less accurate than surgical PCI because imaging can't detect all disease, especially small tumors that are under 0.5 centimeter. But radiologic PCI gives surgeons a preliminary estimate to help decide whether they should go ahead with surgery. Why does PCI matter so much? It predicts whether complete cytoreduction is even achievable. Complete cytoreduction, CC0 or 1, means removing all visible tumor or leaving only tiny residual nodules under 2.5 millimeters. That's the goal because complete cytoreduction dramatically improves survival. Studies consistently show that patients who achieve complete cytoreduction have 5-year survival rates of 50 to 75%, while those with incomplete cytoreduction, which leaves larger residual tumors, have much worse outcomes, often similar to patients who don't have surgery at all. PCI predicts the likelihood of achieving complete cytoreduction. Lower PCI scores means less extensive disease and a higher likelihood of complete removal. Higher PCI scores mean more extensive disease and a lower likelihood of complete removal. What PCI scores predict good outcomes? For peritoneal mesothelioma specifically, most experienced centers consider PCI under 20 to be favorable. Patients with a PCI under 20 are good surgical candidates because complete cytoreduction is usually achievable and the outcomes are excellent. A PCI between 20 and 30 is considered intermediate. Surgery might still be worthwhile if the surgeon believes complete cytoreduction is achievable despite the higher tumor burden. Outcomes are more variable in this range. A PCI over 30 is considered unfavorable. Complete cytoreduction is very unlikely with such extensive disease. Most surgeons are not going to recommend cytoreductive surgery with HIPEC for PCI over 30 because the risk and burden of surgery aren't justified by the poor expected outcomes. Some surgeons use a cutoff of PCI 35 or even operate on patients with any PCI if they believe they can remove all the disease. But most experienced centers are selective and operate primarily on patients with lower PCI scores who have the best chance of complete cytoreduction and long-term survival. Can PCI change between imaging and surgery? Yes, it happens often. Radiologic PCI from CT scans typically underestimates surgical PCI because imaging misses small tumors. But when the surgeon opens the abdomen, they find more disease than the scans had shown, and the PCI is higher. Less commonly, radiologic PCI overestimates surgical PCI if the imaging interprets inflammation or scarring as a tumor. This is why some patients undergo exploratory surgery expecting to proceed with cytoreduction based on favorable radiologic PCI, but then the surgeon finds a higher surgical PCI than expected and decides not to go ahead with the attempted tumor removal. What if your PCI is too high for surgery? If your PCI is over 30, or the surgeon determines that complete cytoreduction isn't achievable, surgery won't be recommended. Instead, treatment would be systemic chemotherapy or immunotherapy to control the disease without surgery. This is not a failure. It's appropriate patient selection. Operating on patients who won't achieve complete cytoreduction subjects them to major surgery and recovery without hope of a survival benefit. Can you lower your PCI before surgery? Some centers use what's called neoadjuvant chemotherapy. That means the chemotherapy is given before surgery to shrink the tumors and potentially lower the PCI. If chemotherapy reduces your tumor burden substantially, your PCI might improve enough to make surgery worthwhile. This approach is still being studied, but it does offer hope for some patients who are initially diagnosed with a high PCI. What questions should you ask about PCI? Start with what your estimated PCI is based on imaging, and could the actual PCI at surgery be different from this estimate? What PCI cutoff does your center use for candidacy for surgery? And if your PCI is borderline, what is used to decide whether or not to go forward? Also, if your PCI is too high for surgery, could neoadjuvant chemotherapy lower it enough to become a surgical candidate? Understanding PCI helps you have informed decisions about whether surgery is appropriate and what outcomes to expect if you proceed. To review, the Peritoneal Cancer Index, or PCI, scores tumor burden in peritoneal mesothelioma from 0 to 39 by dividing the abdomen into 13 regions and scoring tumor size from 0 to 3 in each one. The PCI predicts whether complete cytoreduction is available during surgery, with a PCI under 20 considered favorable with excellent surgical outcomes, between 20 and 30 seen as intermediate, and over 30 viewed as unfavorable, with surgery rarely recommended. PCI is most accurately determined during surgery, but it can be estimated from CT scans beforehand. A lower PCI predicts better outcomes with cytoreductive surgery and HIPEC. Visit mesothelioma.net for more information about this, the surgery, and PCI scoring. Or you can call 1-800-692-8608 or use the live chat feature on the website to work directly with one of our patient advocates. As for me, remember to post your questions below, and I'll see you next time.